Thank you. We've got a video we can run now. We'll get that over with, and then we'll have a dialogue about how we got here.
This is Salvatore, Sal for short. Sal wiped out on his mountain bike, dislocated his shoulder, and tore his rotator cuff. Sal's brother Lou told him to see Dr. Kirk. Dr. Kirk repaired Lou's knee 2 years ago, and Lou's knee is fine. Sal went to see Dr. Kirk, and Dr. Kirk ordered an MRI. But these days, Sal's health insurance makes him shoulder more costs. Ouch. He wants high quality at an affordable price, which seems reasonable. So Dr. Kirk told Sal about Health Engine, a free service started by physicians. Health Engine helps people spend their healthcare dollars wisely. Health Engine showed him what MRIs cost in his area. Sal was floored. From $1,200 to $3,000 for the same MRI. And using Health Engine with his current insurance, that $1,200 MRI only costs $368. Higher cost doesn't always mean better quality. Sal thought it over. A $368 MRI of the same quality would do just fine. Dr. Kirk agreed. The MRI confirmed Sal needed surgery. So back to Health Engine to find a place where Dr. Kirk could perform the surgery. Thanks to Health Engine, facilities can see what their competitors are charging and lower their prices to compete. This is good for Sal, who got lower out-of-pocket costs and the best quality healthcare, all within his existing plan and network. This is good for Dr. Kirk, who thanks to Sal's savings got reimbursed at a higher rate and exposure to new patients. Even Sal's boss is happy, thanks to lower healthcare costs for his business. When consumers and their physicians demand better value from the healthcare system, everybody wins. Health Engine. It's your health, your choice. By the way, the shoulder surgery was a success. Sign up for Health Engine now and get started.
Great. So that's obviously geared around the U.S. health system, which is its own animal we'll talk about later and where Health Engine comes out of. But when I read about what we were going to be presenting, as much of it is the entrepreneurial journey or how I got there or how anyone sort of gets to build businesses, and it was not my intention to really do what I did until opportunity sort of presented, and I was fortunate enough to see it and take my shot. So I was finishing up my medical training. I'd done a business degree and decided I'd hide in school a little more. I went over to Oxford in England. While I was finishing up some of my training in medicine, I had a chance to work in some of the National Health Service hospitals and went back, finished my law degree at Oxford, and everyone said, "What's your next degree going to be in?" And right as I was taking the exams, Tony Blair, this is around 2002, took a look at the National Health Service and said, you know, this was set up in 1948, roughly 54 years earlier, to be free at the point of access, but it had become a 1.4 million employee organization. I think it was third to the Red Army and the Indian Railways back then. And the problem became that it was very siloed, incestuous. And what he announced with his health minister was pretty revolutionary, although a lot of people didn't realize it at the time, and I had no other opportunity to take advantage of, so luckily I got into that. And what they did is they introduced a project where international hospital groups would be invited in to build, staff, and manage hospitals of excellence. I was the only startup. I think hundreds of established hospital groups from India, Europe, America came in on the back of this, and the way they were going to work it is, they said, you've got to bring in new best practice, bring some innovation in, you're going to be accredited, you've got to be clinically audited, so you can't just go off in your own direction, but we're going to basically guarantee 10 years of cases, different types of surgeries, diagnostics, and procedures. And when you build these hospitals, if we don't renew in 10 years, you can force us to buy back the buildings at 90% of depreciation. So I looked at that. Nowadays, I'd look back and say I had no chance, but I went after it. I figured, what's the downside? And roughly 5 years later, we'd grown to be the biggest private hospital partner to the National Health Service, grew it to about $5 billion in revenue, and sold it in June of '07, which was good timing looking back. What we discovered when we did this was, number one, the NHS had, for the most part, always been its own purchaser and supplier. It both took the taxes and then funded the hospitals and the healthcare delivery systems for the most part. There is some private insurance there we'll get into a little later. And what they did was very brilliant. They didn't know what fair price would be for a hip or a hernia or a diagnostic. But what they came upon was, if we create this attractive sort of project with billions that are on offer for those that are fortunate enough, and we set the same outcomes. You've got to back up and warranty your hip surgeries, your cataracts. Now it came down to price. It isolated the variable, which the US still hasn't done. Things are billed on input, how much you put in rather than the outcome, and so everyone's doing as much as they can and billing for it. And years later, I'd find out we were the last bidder on a big project, let's say in Nottingham, multi-$100-million deal, and they'd laugh and say, you were the last bidder for, 3 months bidding against yourself. And the frustration would build, but it was too late. And it struck me that they got fair value for money. What we were able to do, we were the first group to do intraoperative anesthesia in the UK for the most part. We were efficient enough that we could deliver all the government, million cases a year if they delivered them, and we'd always let the government catch up. We were 50% occupancy rate. So you had the doctors and the nurses would finish pretty quickly and be sitting around. We were profitable at that level, but at that point I went to the private insurers and I said, hey, same doctor in the NHS, maybe a day or two a week, is taking someone who's got private insurance, maybe AXA or paying out of pocket to skip the waiting list. They'd rather be in this brand new top-class facility. They're paid the same. The doctors are about 6% of the cost of a case on average, and that's the US and what I experienced in the UK. The building is where the cost is. And so what we would do is we would price down the building where we still made a profit, and we attracted a lot of volume. We got up to 85-88% utilization, and that drove huge profitability. I think that's the first time there was ever a real marketplace that was dynamically pricing in healthcare. Once we sold those, took that lesson and built what are really health engines progenitors. Again, starting with the private sector this time, working with insurers like Bupa, AXA, Standard Life, and focusing on the fact that the clinicians for many of these common diagnostics, surgeries, and procedures are 98-99% of the outcome. You get a good doctor in a decent place where they're happy to do your shoulder or fix your, take your tonsils out. For better or worse, most of the outcome is whether the doc does a good job or not on these kind of cases. Yet, over 90% of the cost is in these places that are just brick and mortar and are usually, I think, on average in the States, half empty. So what we did is we created a competitive marketplace, taking what we learned having done this as the hospital on the other end of Tony Blair's reforms, and now scaling it across the UK and Ireland. Those businesses were sold in 2011, and I, having been in the UK 12 years, planned on being there too, finally came back to try and sort out the mess in the States. Well, it's been a lot harder. If you guys read the papers, you know the US is really overspent, and we don't get the same outcomes as countries that spend half of what we spend per capita. I just read Romania's about 5% of GDP spent on healthcare. It's one of the lowest in the EU. The US, on the other hand, is approaching 20%, which is the largest sector by far. It's about $4 trillion a year, and we don't get the best outcomes. We're last in a lot of the World Health Organization leagues, et cetera, and the question is, why is that? The system's been set up, quite simply, in a misaligned way. So everyone is making money on the healthcare system except the patient and the true payer. And I say true payer because the insurers we found are now in a situation where they're no longer underwriting risk. They're not taking actuarial risk. More often than not, employers, which is where most people in the US get their private health insurance from, are what's called self-funding. They're taking the risk for the year based on their employee population, they and their employees, up to deductible. And the insurers now get a percentage of how much they spend. So if you think about the wrong recipe and why costs keep going up in the States, right there it is. Now you look at the inflation and it's past CPI pretty much year on year. This slide gives you a good indication of how much we'd be talking based on the growth in healthcare spending versus these simple products we take for granted. As I mentioned before, the insurers have been at the helm of the private healthcare industry for many decades. And when I was in high school and I got my academic act together, my dad had retired from disability, he was a doctor. He told me, don't go into medicine. And that's what sort of made me say, wait a second. Is there a disconnect between the docs and the business people and what's grown to be the patient? So this doctor-patient relationship has been sort of disintermediated. And I didn't know it then, but 10 or 12 years later, this was what I would be building as a first business. As Cyprian said, always partnered with the docs, because what we've found is the docs have to compete on quality, but they're not driving the real outsized inflation. I read a couple of weeks ago that if all docs in the United States, about 900,000 practicing clinicians, got paid zero, within 18 months, it would be back to the $4 trillion I mentioned. They're really not the factor in the cost. So you've probably read about Obamacare and the ACA. It's a question that follows this administration too. How do we get better value from the healthcare system? I was in the White House a month ago meeting with the actual policy head and personal physician to the president, and what he's done is, for the first time, he said, patients who are on the hook for, up to $15,000 in their network, and millions potentially for an individual if they go out of network and don't even know it. It's the leading cause of personal bankruptcy in the States, about 72%. And what did President Trump say? He said, you know what? These plans that have agreed the rates, and they can vary hugely within the same town, two equally good facilities, they got to tell them what those rates are ahead of time. And that's sort of what we're doing as a first step in Health Engine. I'll tell you where we're unique and the only ones doing what we do. They're already fighting them. The fine is $300 a day for a hospital. These hospitals turn over sometimes many hundreds of millions or billions. They'll just not publish the prices. People will walk in unknowing, and they'll pay $110 grand a year, so it'll have no teeth. And when I set about going to the States to build this, someone said, it's going to be harder than when you built it in Europe, because these are the deepest pockets who have been winning off the system for 30, 40 years, and you're coming in to basically reveal and take their lunch away. And I didn't listen. I thought, you can't keep what's good from happening. Sure enough, these guys, they tried to buy us really quickly. They wanted to block. Now, we're a free platform. We only make money when we help save money for the patient and their payer. And still, we've had battles with the insurers where in private they're trying to spread fear and uncertainty and all this sort of thing. So about 10 years ago, some groups, prominent among them Castlight, which is a SaaS solution, they started to figure out what a lot of people knew, which is that the insurers don't really create a competitive pricing market. They'll walk into one hospital down the street for the first time in 5 years. They'll agree 6% increase on all services. And then 2 years later, for the first time in 7 years, they'll go to, let's say, an equally good hospital your doc would bring you to as well, do the same thing, say, see you in 7 years. And what you find is the first hospital might be now at $10,000 for a knee scope. the one down the street that they see in a couple years could be 30,000. It's that much of a factor of difference. And without transparency, people can't see that. But even in light of transparency, what Health Engine does is go further, because when a facility is revealed to be 3 or 4 times the price, we're talking maybe tens of thousands of dollars, compared to an equally good one your doctor's just as willing to take you to, what does that overpriced facility do? In any other marketplace, they start to reprice. Well, they can't. They can't lower their price. And they're not going to see the plan, whichever plan we're talking about that the patient has, for maybe 5, 7 years. Health Engine allows them to reprice. So we're really a marketplace where you reveal the disequilibrium in pricing and then say to the providers, all eyes are on you. You're the commodity here. You're the room. The doc's as happy with you as he or she is with 3 other places. What do you want to do? And that's basically turning over billions of dollars that we're helping to save just by revealing the prices and then letting everyone react. It can never go above what the insurer agreed, but now it can come a lot lower. And one of the things I learned quickly running and owning hospitals is that the actual marginal cost of a case is low. Most of it's fixed. So if you're half empty, which on average most facilities in the States are about 48% occupied, that next case you might get $10,000 for, but what's the cost of it? Glove, gown, maybe a surgical shaver, let's say $500. Now when someone can see that and as good or better alternatives, you sort of come to Jesus, as we say. You say, well, I can hold out for $10,000, I'm going to get paid by their insurer and get 0, or I can come down maybe to $2,000 or $3,000 and be competitive on a spot rate. So where the doctors come in, the clinicians, is you'll see a lot of activity in the States around bundles. And we looked at that and said, look, the docs have to compete, the clinicians have to compete on everything we want out of a clinician. Good outcomes, technique, bedside manner. Some people will choose different doctors for different reasons, but taking them out of the cost equation, because they're only 6 to 8%, simplifies the cost of what's variable with the facility. It untethers them and allows us to truly bake off the facilities. I always say it's like the airlines. Once the FAA has said these airlines are equally as safe, at least we hope they're doing their work to do that, that's the main concern we have, just like when a doctor says you'll get the same outcomes going there as these other places. Now Health Engine can tell you these wide variations in rates. Without the doctor, people are scared. I always say, what we do, unless it's the birth of a healthy child, most people don't want to need. They want to just think, I have insurance, I'm safe, but insurance is the beginning of the ballgame, as I said. Under the regulations now, you can spend up to $15,000 if you stay in network in any given year before you're fully covered. And there's cases where someone goes to an in-network doctor, in-network hospital, and an out-of-network anesthesiologist comes in. The whole case costs them, the patient, maybe $3,000 with their co-insurance and their insurer covering it. That anesthesiologist bills them $115,000 and can chase them into bankruptcy. So I'm not saying doctors are always on the right, but when you separate it out from the facilities, it becomes a lot easier. Premiums, again, as I said, there's very few real fully insured plans out there. They're going away. The insurers have gotten smart and passed the risk on to the employers and the patients, but they're still responsible for agreeing these rates, which people are starting to see are totally inefficient and there's no marketplace. There's a statistic that's now, I think it's 70% of employers with 1,000 employees are offering high deductible health plans. Well, that's nice, but if you don't know what the price differential is, it's like walking into a restaurant where it could be $5 for a salad or it could be $500. Without that information, how do you choose? Again, the physician component, separate it, let it compete on quality and outcome, and use the physician as the Sherpa or the guide to help create the competition between the facilities. It's been extremely difficult. It's the most regulated industry in the States, more than financial, because as Danny, who presented a couple speaker slots before, if you were here, he said it right. If you introduce a new taxi that's, Uber with GPS and Airbnb, what's the worst case? You get lost, you don't end up at the right place. Healthcare, we're not really consumers. We need to be told by a trained individual or individuals what's wrong, and then most likely, they then suggest the fix, and you're already down the rabbit hole. So it's difficult to kind of get in there at the point of need unless you can co-opt the doctor to bring this in. And that's where we started to pivot the model. In the beginning, we went out to employers and said, hey, you guys are spending a fortune, and it's going up each year, and now you're taking the risk on your P&L directly. What you find, though, is they're happy to be as bad as everyone else as long as they're not worse. Meanwhile, the employee down the hall who's looking at a personal bankruptcy is desperate, and they don't have the tools. I've gone into employers that are 200,000 people, and those are healthy individuals who might or might not need what I offer during a year or the next 2 years, and they don't want to think about it. A doctor happens to be the magnet for the needle in the haystack. That's where people that need what we offer show up, and they're also the ones that can solve that issue around equivalence on the commodity aspect, the room. Even so, we're not the first to figure out where all the cost is. We're the first to democratize it and bring it back to patients and payers, and that's causing a lot of these deep pockets who've been winning on $4 trillion a year to react against. And what they've done is they've gone out and employed doctors. And I hear from doctors that if they tell their patient, I work for this hospital, but down the road is the best for what your son or daughter needs, and that case leaves the system, they'll get a visit from the CEO or CFO the next month saying, you're leaking off the P&L. If it's the CEO's daughter, by all means, but no one else, because, we're good enough. And financially, it's even worse. Patients can be out of network and go virtually bankrupt overnight, and doctors are afraid to help them because they might be fired, and this is really amazing. I mean, I've sat with senators and regulators and said, don't you think doctors should, regardless of their economics or employment, owe their duty to the patient clinically and financially, first and foremost, before the profitability of the system you work at? And they say, of course, but the doctors will look at me and say, yes, but I'm scared. I don't want to be bullied by these business guys in the executive offices. So it's extremely tough to do. And again, the consumer engagement side, people don't even know how the system works today. So providing a solution is a longer-term exercise in scaling. Much of what I already said. I'll leave a few minutes for questions.
Thank you very much.
Sure.
I would start the first one. You said that the healthcare market, the healthcare business market, is almost $4 trillion.
Correct.
Trillion now. So, how much of this market can a solution like yours help?
About 80%.
But in terms of reducing the cost.
There was an estimate done, Congress brought us in, the U.S. Congress. It was when Paul Ryan was Speaker of the House. And they conservatively said, Health Engine's model, if extended writ large, and it can be scaled because it's not a hospital here or a hospital there. It's sort of like Amazon versus just the bookstore, was $800 billion a year. And while outcomes go up, because when you compete transparently outcomes, there's a motivation for doctors and facilities to work together to get not only cost effectiveness, but better outcomes, more efficient. And you find, there's a statistic, if the Mayo Clinic, which is a renowned hospital, one of the best in the States, if it could treat all 330 million Americans, costs would go down by $500 billion a year, and outcomes would arguably go up. You've got one of the best systems writ large. Cost and quality in healthcare are actually inversely correlated. The better places have their act together and can not only be better clinically in systematizing their best practice, but they also get better in costs and economies of scale. But most people in the States think that a market exists when it doesn't, so you get what you pay for. And it's actually quite the opposite.
To give you a bit of an example of how healthcare, private healthcare might look in Romania, you have, let's say, a series of 10 to 50, even 15 to 50 hospitals and clinics, etc. And you usually can just choose whoever you want. But the process, and correct me if I'm wrong, you call, you know who, and then you know who, and then you know who, to get an appointment. And eventually, at the fifth call, you might get somebody. Would a model like yours work in which I say, I have a problem with my knee, I have this much money, and you would find automatically the best one in the city?
Even better. One of our advisory board members, years ago when I was building this in the States and had seen it work in Europe, he said, how can you get providers to take less? I picked up the phone and I called an MRI center, and I naively on the phone said, oh, hi, I'm just Joe Blow. I need an MRI of the head. And they said, that's $4,200. That's what they charge everyone that nobody pays unless you're uninsured, then you're going to get stuck. And I said, oh, you know, I have Blue Cross. And they said, okay, that's $1,800. There's a charade of rack rate versus real rate. I said, oh, you know, I'm on a high deductible plan. My friends told me about a place that's a little further. I'd rather come to you. They said, $300. Come tomorrow at 2 p.m. I said, I can't. They said, come whenever. Because they're half empty. The radiologist is the direct cost. If he or she isn't employed, maybe 30, 40 bucks. If there's contrast, which there wasn't, it might be another 20 or 30. So their marginal cost, again, I mean, the lights are on, the salaries are already paid. Those are sunk costs. The machine, they'll come down by 80, 90%. We're reducing it for the same service.
Any questions? I have one last. No. Who makes the money? Because if it's 4 trillion, then somebody makes the money.
Yes.
Then if you come in and say, I will take down 800 billion,
Yes.
somebody will lose 800 billion.
That's right.
So those people might, well, I would say stop you.
They
You're a
tried.
fit guy, but
They tried to buy us really early on, when we were pre-revenue for $300 million, to probably just shut us down because, and hope that we were happy to go off and golf. And I said I wouldn't do it because I couldn't see the system continue to be unsustainable, and I'm not so much into the money. To the shareholders I didn't say that specifically. I said, if the giants are already stirring and willing to buy us dead at that price when we're nothing, there's gold in those hills. And that they liked. It's just like with Uber. If the taxi associations hadn't fought, no one would think there's anything sexy or disruptive there. But yes, absolutely. The head of Blue Cross Michigan, which is a nonprofit and a small one, last year earned $36 million salary. So where is the money? It's in the brick and mortar and the systems and the insurers, but not for the taxpayer, the shareholders, or the patients, and certainly not the doctors. People think the doc, because you can find a doc, that's Dr. Smith, they're identifiable, they usually are earning 6 figures. The white coat gives it away. But then the executive who's the Mr. or the Miss, they're sort of anonymously walking the halls. They're the ones earning 7, 10, 30. The CEO of Aetna, who I know pretty well, is going to leave with $600 million personally.
personally.
He did the deal with CVS, and before that he was earning 30 to 50 million a year. This is where the money is going. It's activity-based and not outcomes-based.
Yep. We have 5 seconds left. 4, 3, 2.
Thank you.
Thank you very much.
Great. Thank you.